and 1.5 of her said, and so I got another 1.5 here to just bump it along as we go. But she's definitely there. And it's funny, I mean, I've just sort of evolved on how I do my sedations without having any. I mean, obviously I had training and I'm an evaluator for the board, but you sort of have a feeling of things, and I'm doing more Demerol than I used to do, and I'm doing it a little bit faster than I used to. Yeah. It's really hard to play.
Yeah. Hold on a second.
But sometimes you want to get in and see
Thank you.
how it's
You can see, right?
Yeah.
Okay, so what I can feel when it's on the tuberosity, it's on the back side of the tuberosity, right? And so now I'm just going to go a straight line straight up there, about in the middle of roughly the middle or the middle ruffle,
In the middle.
And I can feel the bone when I'm doing this, right? Because I'm staying on the bone. You could use a 15 for this, but it's going to be hard to get way behind the tooth like on that. I like the 12.
That's the corner that you talked about.
So then on our flaps, we just start with the patella and just get the patella, off of the bone.
So what did you say the periodontist usually they ask you to do the incision first and then?
The periodontist would absolutely have a conniption fit. They would be talking about how much attachment we're losing here, and that this is all brutal and rough and all the rest. But this is the way that it's done in maxillofacial surgery. So that's about how long it takes to get the flap open. So now it's ready to go.
Yep.
Okay. And this one, I can see. So you look at I don't know if you can see this or not, but I can tell by looking with my loop that I can get this instrument. I can peel the bone off of this. Sometimes you'll see that you can kind of tell the bone's a little thick just by looking at it, and I use the drill. This one I can see I can get my instrument up in here, and I'm going to be able to remove some of this bone. See? Can you see it? Okay, and I'm just going to start to peel it away like that. See? And that's another thing about the younger patients, right? I mean, I keep talking about harping on the early removal. This is one of the reasons. If this was a much older patient, you couldn't do that. Yeah. So I basically have got everything over there. As soon as I get this really open and clean, I'm going to show everybody what it looks like. Okay, there you go. I can actually see a little bit of the tooth there now. So everybody can take a look at it. Can you see the tooth? If you can't see the tooth, Manera, just a little more. Did you see the tooth?
It's shiny.
The little white corner there?
White corner.
Can you see it? Yeah, you see it. Okay, so everybody can see that the tooth is visible, right? Okay, so if you can see it, and it's a young patient, 90% of it's there. The rest of it is getting this in and then feeling where it is. So this is the concave surface, right? So, and you see the little teeth on there? So this is going to go up in here between. There's the bone, and then I can already feel it slipping in a little bit. But see what I'm doing now. Watch on there. See, I'm behind the monitor. See how it's going back and forth? This is in your manual. There's a diagram. But see what I'm doing? And I'm moving it a little bit further in as I do this, as I advance. I can feel the tooth moving a little bit. I'm going different directions and letting it get really solidly against the tooth. Once I know that it's in there all the way like this, now I'm going to do, this is the movement. I'm going to kind of pull up, just kind of lift up with this, and then kind of towards the buckle, like that. And I don't think that came out all the way because it slipped a little bit, but it came close. So I'm going to go back and just repeat the same motion again. And there's a little opening here. We've got to close that up. So same thing. It's really still solid. I can feel the instrument in there really solid. And I can feel it pop, so it's too solid. I mean, look at the tooth. There's no roots on it. They're very little, right? This is the cases that you guys should be doing. And the ones that I think, this is the ones that when I went on Dental Town, I put a case like this up there and they go, oh, no, you should wait. I say take it out now. It's so easy, guys. I promise you that you can do this, okay? It's so easy. I'm not trying to sell this, but if you don't feel comfortable with it still, I can come to your office, but I'm not going to do it for free because I mean, you need to schedule me some patients or something where I can make some money, because otherwise I'd be doing it here, you know. But I'm happy to do that if you want to come in. Actually, it'd be kind of fun to do that. Oops, we got a little bit more in there. You want to get, this is important as far as the infection stuff, and to try to avoid what happened to Sean. You know, you leave this stuff in here, you're not going to get you could have a cyst develop for sure. So far you've seen 3 sedations, and they're all a little bit different, I guess. This is probably 50% I like this patient, unlike the first one. So I've got everything cleaned out and debrided. You can see what it looks like. The edges of the bone are pretty smooth, but I'm going to just use you can use a bone file. Sometimes I actually find a bone file sometimes makes it a little bit rougher, so I just go over the edges a little bit with this, just to make sure there's no loose pieces of bone there. Well, you can see what it's done, so we're going to close this up with no sutures. That should be the end of it. Okay. So we'll take this out, and now I'm just pushing to make sure that the bone, if it did pop out, that the bone's backwards. Usually the bone isn't expanded out on these, but if it is, you want to push it back. And then I'm feeling to see if there's any sharp edges. And I have none of that, so we're done. On to the next one. Like that. Same thing.
Is there a reason you don't go to 32 after you already have the bite block on that side? Is it just because of that anesthetic?
You know, I've never really thought about it that carefully, but I think if I tried to, you know, I probably at one time they had a reason. I think it probably is because, yeah, if you upper ones, they can be really difficult, like the distal angular ones. If it was a fully developed distal angle, I would just refer that out. Actually. See where I'm going? Way back there. Okay. This is really hard to see, but I do have a diagram in the book about that in the manual.
You can lean on me, that's fine.
Did you do about 45 angle again?
No. This one is more like kind of. It starts straight behind the second molar, like halfway.
Did you ever see?
I have a spot having no hair. Did I show there?
I didn't see it.
Okay, good.
I didn't know.
Make sure you raise that part.
On YouTube tonight. What's your practice name?
Hey Sean, your name tag's on this.
Again? One time I found at the back of who? You're the
Patient was walking out.
See, this one's a little bit harder on the bone, but yeah, I'm going to use the drill on this one. Even though it's the same patient, we're going to use the handpiece on this one. This tooth, I think, is a little bit more to the palatal side. So we're going to do that little zipper thing, you know, the vertical thing with the bird, just to get access back there. This should be pretty quick. So I'm going to look at the x-ray and make sure that the roots are not, the second molar roots are out of the way. So let me get in there first. I'll go ahead and suction all the way up there. And then take the suction out. Take it off for a second. Get the position. Okay, right there. You see where I am? Okay. You just see where the bird's way up there? See where the bird is? Way up there? Kind of next to the second molar root. That's all you need, like that. And just making a little bit of opening so that I can get this guy in to peel it back.
My mistake, my flaps are much more than that.
I know, that's
I think that's one of the biggest
that's universally true.
So it's like,
yeah, and you can
so
see this
I wiggle the tooth and I don't have room to take it out.
Yeah. Yeah. Okay, go ahead and suction right there. See, this definitely is more to the palatal side. This one's way over there, actually.
You got a nice position on this one.
This is really this
This
is very different from the right side. This one is about half a tooth to the palatal side. So this is a kind of a it's going to really throw you off if you open and you see that one like this, because you're going to be looking for the tooth to be out here on the buckle where it usually is, and it's not there. Because I don't know if you can see it or not.
Cut in the burr and just peel away right now.
Yeah, you just go in about maybe maybe 2 millimeters, deep with a cut, so that you're not going very deep. That way, if you're actually near the root of the molar, by mistake, you don't actually get the root. Just enough so that you can get this guy into that little notch, the slot, and feel the bone. The bone's pretty soft. The reason why it was like on the right side, I could get this in because the tooth was more to the buckle and the buckle bone was thin, so it just peeled away. On this side, the tooth is more to the left, which is really unusual that it happens like that in the same patient. Usually, it's the same on each side. This one the bone was really thick, and I couldn't get this going. So I had to make my little slot and then remove this away. Yeah. Oh no, it's just a few seconds. Okay, so you can see the tooth there, right? Did everybody get to see the tooth? Where the tooth is there? So it's a little bit more to the palate. A couple millimeters makes a difference. It gets 2 or 3 millimeters to more to the palate. It's going to be a more difficult side. You can see it's over to the palatal side a little bit. So we're still going to do the same way. So now we got this guy. Let me see here. Okay, so now I kind of got this where I think I can feel it. Yep, and I can feel the flat surface there. And it's kind of advancing. When I'm doing this back and forth, I'm getting the instrument in there farther. I'm trying to get it so that it'll stay in one place. So that one's done. So now we got to clean up the follicle part because she's young, so there's going to definitely be quite a bit of follicle. Well, I'm constantly pushing this gauze back into place, to make sure that nothing goes back there. It's especially important right before you take the tooth out, because if it jumps out and goes behind the gauze, then you're going to be in trouble trying to get that tooth. The patient could aspirate it. I'm not going up at the occlusal part, right? Just staying on the side. You don't want to go up at the top. It's going to punch it into the sinus.
Right.
Roundhouse top teeth on all molars, pulse and crown.
Okay, good. About this just a second. Get this follicle stuff out. So on the follicle, sometimes I'll grab it and kind of like go back and forth like this, just kind of like peel it. See more coming out? And I'm going to re-grab it closer up there so it doesn't break. Try to get as much as I can of it out. Try to let go and move it.
Scissors sometimes just to cut it and hold it like this. And I didn't know you can peel it off.
Yeah, you want to peel it because, what happened to Sean? That's probably because this tissue was left in there. It's a nidus, for a cyst. You have the epithelial tissue in there. And one last check on that, and we're done. Now we're going to do the same thing and feel it, make sure that everything's back in position.
So you grab it and you pull it and grab it.
Yeah, just kind of, want to be delicate, because if you pull too hard, too fast, it's going to break it. And then then you're going to leave a lot of it in there.
Right.
Okay, so that's it. We know what's coming up.
You do the buckle, nerve, and the...
Now I'm doing the buckle. I did
the marking.
Yeah, with the mark, I know, like... That one is sometimes when you do that, they'll jump a little bit because that the first marking was on top of lidocaine, so they don't feel it. But the second one is not. It's fresh. So I do that. You don't have to hang around your teeth. This is probably boring tell for you. No, it's not boring. No, I got you covered. Yeah. One side and the elbow, his dad did the other one, and we did it exactly the same way. Exactly, but I did get a couple little pointers, like the one suture thing. But as far as the rest of it, it's the same.
So you treated your daughter. Yeah. Oh, that's cool. Kudos to you. Those are the ones that you want to
prefer. If given the choice, I guess. Oftentimes you don't get the choice.
So we're going to go to number 17 next. Let me just move this around first. Oops. Almost got me there.
The biggest fear is the parent.
I treat them like that.
Okay, good.
Yeah.
My mom is real cool.
Sometimes on the lowers, I'll actually move the chair because you can move the chair whatever works best for you. But this is we're looking down, so I can move the base a little lower, because we got a better view looking down. And standing up is the only way that I can do these. I tried it sitting down; it doesn't work very well. All right, so let's see what we got here. See, it's kind of a small mouth opening, That's one of the things that, is part of the assessments. It's in the manual. It talks about...
Is it a small mouth?
Yeah. Well, small, there's small jaw and then small soft tissue opening. And then it's kind of a small soft tissue opening. I'm going to use this guy first. I got to do my infiltration first. So this is for the hemostasis for epinephrine a little bit here. I just all over the place here. I don't know where my flap's going to be. Okay. Boy, I can't believe how good these cases are, Jonas. I mean, I couldn't have picked better cases for today. It's amazing.
I was going to take the last one.
Yeah, I know. Yeah. Okay, I know this is going to be a pretty easy one too because there's a lot of room in the alveolar. So look at this one and look at the to the middle of the tooth there. And I just stayed on bone the whole way there.
Well, I think it's the same concept.
Yeah,
so
it is.
when you pull with a Minnesota detector, then actually it's kind of in the middle.
Yeah.
Not middle, but towards the more upper side.
So I'm gonna remove this. I'm gonna do my distal wedge. So I'll do this and then I'll stop and show you where that is. Okay. Can you see the wedge of tissue now? There's a wedge of tissue there. I'm going to remove that wedge of tissue. Wow, it looks really good, Wayne. Really good. Yeah, you can see this one really well. Okay, so let's go get this little piece of tissue out. Okay, buddy, section that over there. So, okay. I try to get it so that it's not really loose because otherwise it would suck up in the Meniere's suction there. But I get it close enough that I can pull it out of there. Like that. And so now we got our little wedgie out of there. Now somebody has to hold the chin really well. So we don't have TMJ problems, right? So hold it like that really hard. Okay. If you don't support the chin, you're going to cause some TMJ problems for sure. Especially when the patients are sedated like this. So be careful about that. So I'm on the bone all the way, and there's your flap. Okay. This one you can actually see a little bit of the tooth after the flap. Actually, the monitor is looking really well, right? You got this little thing right up there, right?
Yeah, the way you have the patient turned and the camera, it's very nice.
Yeah. I haven't been looking up there, so I don't know what's going on, but it looks pretty good. Yeah. This is what's good about the DVD, because we can pick, like 4 cases, take the best out of 4 cases and make one really nice DVD.
Wayland's greatest hits.
Huh?
Wayland's greatest hits.
Yep, it's top 4 hits. That's right. Okay, so let's see. We're going to do this next.
That lip out of the way is really helpful.
The lower lip?
Yeah.
Yep.
Just for visibility.
I think you can hand me the bone file. I can retract with the bone file, the lip. Yeah. You got it with your finger? Okay. Sean, you want to retract the lower lip?
But if you're going to do that, use this. Or a mirror would be even better. But you could do this with this sound like that if you want to. Just remember, I got to get in there to do something too. So we got all these people in there. Okay, we ready? We're going to do this. dropping and stuff. So,
It's much better. Beautiful. That's nice.
okay, here we go. I'm learning along with you guys, you know.
Go ahead.
Water. Okay, hold the suction all the way down there. Just leave it there. Leave it right there. Leave it there. Okay, see how the water's cooling? Did you notice that? Mm-hmm. Okay. When you hold the suction in there, when you have your assistant for the suction in there, try to have hold the suction tip on the bone.
Okay.
If it's on the soft tissue, it's not going to suck up very well.
Okay.
If you hold on the bone, then you get irrigation, but it still keeps the seal clear so you can see. Because when it pulls up, you're not going to be able to see what you're doing, and you're going to make mistakes. So the suction should go like right there. Yeah, perfect, right there. Okay, it's going to be hard to see, I think, on this again, but
The water? Irrigation.
yeah, a little water.
Water.
Push water. Yep. Good. Okay, I'm going to stop there in a second so you can all see this.
Stop.
Okay, perfect timing. Now they can see the cloth, right? Wow, Wayne, that is good. Really good. Yeah. Did you see the difference between this cloth and the very first one I did this morning?
Yeah, it was wider.
I went to where the tooth should be on the panel, but it wasn't there. And I was too far to the buckle. And usually the tooth is here or even more to the buckle. It's and the lower one, I've never seen one as far as, lingual as that one this morning. But basically I made my trough like this where I started it, and then I found out the tooth was lingual, and by the time I got the bone lingual there, I had a huge wide trough. But it shouldn't be wide, it should be, that's actually, if you look at how that trough compares to the suction tip, that's fairly narrow, right? So narrow and deep enough that you're not close enough to the nerve, but as deep as you can go without being at the nerve. And now you can just section kind of like where the buccal groove is. And you're not going to suction all the way around, but okay. So here we go. Let's switch places, Manira. Okay. I'm going to go on the distal. You go on the mesial, okay, with the suction.
Oh, okay. I'm sorry.
Can you go on the mesial?
Yeah.
Try that. Is that good for the camera?
Yeah.
Very good, too? Okay. We move the suction right over here. Okay. Over there. Okay, good. I might be going a little bit more to the lingual than some of you because I've done this a few times, but be careful on going to the lingual in your section. Everybody see where the elevator is there?
Yep.
Okay, so what will happen is that you're not all the way through, so you just kind of twist this a little bit and you're going to get popping sound. Hear that? A little cracking? That's the completing the section with that. And let's just see if this works on the distal. This guy. I'm not through enough on the. It's starting to come. Yeah. I'm not through enough on the lingual. We're going to go a little bit more. So you can do this too. It's better to go slow on these. I'll do a little bit more here. I'll be really careful because the lingual nerve has the most unpredictable positioning, and it can be really close. It can be above the alveolus even. So be careful with the lingual nerve.
Okay.
There we go. I'll show you right now. I'm going to show you right now why. I just took the distal out, right? You know what? Watch this. I created space right back there, right? So watch what happens when I get to the mesial. See that?
Okay.
So I just created space to move the mesial root. With the distal one, it's a little hard because the mesial part. Yeah. You get it. I just created a huge space there for the mesial to go.
It happens.
It's just flopping around. Sometimes these are frustrating because
they go back.
they're all there, ready to go, but you can't get it out. There we go. So that one you can see the mesial root on that developing. Not all the way developed. Debridement here. Nope, no water yet. Not yet. Thank you though. Thanks for the thought.
Hemostat.
Yeah. And first we're going to get this stuff out. There's a whole bunch of it here. I'm going to get this loose and then
Let's see how he gets it loose.
see.
Yeah, sometimes it's tight there.
Yeah, very, very tight. On older patients, you shouldn't see this at all.
Right, because if
On a
they're
fully developed
impacted,
tooth, you're not going to have any
they're
problems.
gone. Right.
You're not worried about the lingual nerve when you're doing that, going after it.
Well, no, because what I'm feeling is bone, you know?
Okay.
I mean, I'm keeping the instrument on bone all the time, not on the soft tissue. Okay, that's it. And, I don't know, I just get in the habit of doing that. Now we're going to, like, really flood this with irrigation in the flap area. And then we'll switch this over to the small
What
suction.
is that little white thing at the base? What is that?
Good question. Some of the developing tooth, I think.
Right.
It might be part of the, like, the root starting out. See, I would have, normally my inspection comes after I get this one on, you know, because this one I'm going to be really trying to suck up everything and then look and do all my checking at this point here. So first in the flap, you see how pristine the flap is? It's really clean there. And then I'll go in here and look, this is where I'm checking. I want to see if there's any, like sometimes you'll see from the, when you elevate the tooth, even this lingual plate might be fractured.
Yes.
And then you want to push it back in there, right? Otherwise you have a point on the lingual that comes up. And that's it. It looks really good, right? So I would ask my assistant, you know, he knows enough that we work together all the time that he would tell me if he sees something like I might miss a little piece of tooth, he'll say, hey, check the lingual, and I'll know.
So with the lingual, you see a fracture, how do you stabilize it?
I would just take this out, push my finger, push it back in there.
And you have to make sure that it came back in position.
Yes. I still love doing this stuff. It's great. Otherwise I wouldn't be doing it. I don't really have to do this anymore. A big bite. By the way,
Sometimes
this
it's
suture.
hard to get in the same time.
Exactly.
Yeah. Well, okay, but you know, the part of that probably has to do with which suture you're using and what size needle.
Size 3/8.
I mean, if you're using, like, this is 3/0, and look at everybody look at the shape of the needle here. Okay, this is kind of important what we're talking about now. See how it's a half circle, right? And it's really broad. This is great on the 3/0. You can use this, and you can go from the buccal flap to the lingual all in one without, you don't have to go twice.
3/0
So,
and 3/8
yeah.
of the circle.
This is the half circle, I think.
Half circle.
Yeah. You can tell from the picture, you know, it's going to be longer. It's not going to be as sharp. It's going to be a bigger diameter, I guess, is what I'm trying to say. But it makes it really easy to do your sutures and get it in there in the right place and everything. That kind of loosened up a little bit, so I'm going to tighten it again. I want this to be really tight.
I think it's diameter of the they always the thickness of the
Okay, I got it.
of the cord.
Okay, thank you. Maybe down there. Sort of stuck on there. There we go.
Yeah.
I think I got it. I'm making a mess out of this. Yeah. I gotta start over on this one. Shoot. This happens sometimes. I really want these to be really good, you know, these sutures in there, so if I don't get it tight, I'll just start over and do it again. Oh man, I'm really bummed that Rigo's not here. He didn't say a word, he's gone.
He left just halfway through lunch, I think.
I wonder what happened to him. I hope he's okay. Okay, let go. Because I want to see how the flap, you know, where to put the suture. Yeah. See what I mean? Now that's all is laying there, I'm going to make sure this papilla is in the right place, right? So now that I know this there, then I know where to put this one. That's going to be good right there. Another one right there, that's good. It's nice and solid. Okay. It's not bad. But this would be better.
It sure does.
Let go.
Yeah, I got it. Okay, that's perfect. So this is, right now it doesn't look that good. that once we compress it, it's going to be perfect. It's kind of rough right now, but let's take this. I'm just gonna kind of push the buckle a little bit to adapt the patella and everything, the flap, and then a little bit on the distal part. And voila, it should look really good now. You can look at it. Looks good. Yep. So
You can see the Asian line better.
It looks good.
one more.
That's it.
4x4. On the gauze, the 4x4 gauze, I have this listed, I think, in the manual too, but this is 8-ply filled, so there's little cotton particles in here. Don't get the one that's unfilled, because it's not very absorbent. If you're going to use the 4x4s like I'm doing, this is the best, and I think it's listed in the manual under the all the instruments and stuff that you need.
I was using just a 2x2 that I'm opening. Right?
Yeah.
And
Yeah, this works really well.
You have to change it, and
Yeah.
And I don't have this. The system has to hold with the marrow.
This is a small one.
I like that.
Okay, we're doing our little epinephrine thing here.
If you,
It's the same thing though.
but yeah, you're good.
I'm going to try to do this one kind of fast so that we can take a break and get ready for the next patient. Actually, we're doing really good on the time again. Really good. So, let's see. We're lucky on the sedations, so they've been good, yeah? Sedations have been really good. Yeah. Yeah, really good. Okay, sometimes we'll do an extra, a little bit more Vaseline, maybe. Maybe have some there. We'll just put a little bit right in the corner here. Not much, just a little bit, because if too much it gets on the instruments. Yeah, right here. Yeah, okay, that's good. That's good. Okay, here we go. So this is going to be just like we did on the
Do you want
last
to
one.
see Sean?
Come on.
This is where we're going. This, to me, I think I got this in almost exactly the same spot as the left side.
I guess you need to use that, yeah. You want to retract the lip?
This is the same way it was on number 17. It's out to the buckle a little bit on the external oblique ridge and go down all the way to the bone. If you go to the bone and then you have a sharp blade, it's gonna be a nice primary. There we go. It's gonna be a nice primary incision. You're not gonna have a real ragged edges and stuff on it. So now we're gonna do the distal wedge. I would say that the distal wedge is kind of optional, but I like it. I think on the lower especially it helps. Yeah. It's going to just be a nicer closure, and you don't have the fiddle pocket. So the periodontist would like this part.
Yeah.
They won't like my flap design, but they'll like the distal wedge part. It's just interesting too. The literature shows that on third molars, even if they erupt into normal position, really good occlusion and everything, the bacterial flora there is different from other parts of the mouth, and they have more bacteria that are not healthy. So, okay, so we got somebody's got to hold the chin here. Yeah, thank you. So I'm just staying on the bone, and keep pushing on the bone. So you get it open, and something's holding it here, so I'm going to probably adjust that. Okay, it looks pretty good. Let's hold it a little bit more up here, so it's not too much tension there. Yeah, there's something. There's a little bit of tension back here, so let's see if we can get this better here, right here. Come on, baby. Scissors aren't working very well there. Okay, that's better. So I did get a little bit of release there from doing that. I just kind of opened it up a little bit more right here. Okay. Doing good.
This would be
Good. I'm doing good. That's cool.
this would be the same incision retraction for a Ramus graft, correct? Ramus bone graft.
Yeah.
Not that
Yeah.
doing it. But
On this, okay, try not to retract. This is ballast.
Yeah.
You can use it, but what's happening when you do that, I know that it's sort of an unconscious thing and it's just sort of sitting there saying, hold on to me. But if you're using it to retract, it pulls the tongue back and your pulse oximeter is going to desaturate.
Okay.
You're not going to get oxygen. So just let the weeder stay in there.
Mm-hmm.
It's cool to retract it like when you're doing sutures and you need to have a little bit more room, but just do it for a few seconds to get the thing done and then let it go.
What about if the patient is cut like without sedation?
Then it's no problem.
We can retract with that.
Yeah, it's no
right?
problem. They're going to tell you, if they're conscious.
Right, it is too much.
And plus they can cough, right? And they can
Right.
clear their airway. But this patient might aspirate
Right,
instead of coughing.
right.
Okay, here we go. So, same thing here. We start.
Irrigation.
You ready?
No.
Okay, here we go. Hold it right on the bone there, Manera. On the bone, right there. Perfect. Perfect. See the difference when the water doesn't cool?
Water.
She's doing it. She's doing it. See how it's not cooling though?
yes.
That's it. I think that's really important because if it cools, you can't see very well, and if you can't see, then you're going to make a mistake. So try to get it so you can see really well, and I can see the tooth now. I'm going to stop and just look and visualize where the tooth is. So before I do my troughing. So I don't normally I would have just gone ahead and did my sectioning all in one without stopping, but I want you to see what we've done so far in the tooth. I haven't started troughing. I just uncovered the tooth there. And you can see the tooth sitting there. So now I know where to go with troughing, right? I'm going to go about halfway on the distal, and then all the way around to the mesial. Try to go fairly deep. I'm looking at the X-ray, and the nerve is really not very close here, so should be able to be fairly aggressive with the troughing part. So here we go. So we start here in the distal. It's always really loose in the distal with a young patient. Just part way. It's about halfway there. You don't need a lot in the distal. You want to go way up here on the mesial. You can see the troughing. I just started my sectioning and then we ran out of water, so I stopped. You can actually kind of see what's happening here. I mean, halfway buccolingually. Don't, cause you know how the mandible flares out there? And don't go all the way to the lingual side at the distal because there's going to be a concavity there and you could go through it. That's where the nerve is often located. They're going to have a numb tongue afterwards. So. Yeah. It's kind of like section.
You're carrying it right to the apex of the alveolus.
Apex of the alveolus?
Well, I mean, you're carrying that. You're troughing. How far around the distal are you troughing?
Halfway.
Okay.
Halfway. And also, there's something I don't talk about. I'm not talking about very much here, but I thought of this. This is important. As far as the depth, it's around your trough. It's not uniformly the same depth. So on the distal, it's shallower than on the mesial. And if you look at an X-ray, you'll see why. When you see the tooth down there, the nerve is kind of coming down and going down like this. It's going downhill on slope. So the mesial, the nerve is farther away. You're much safer to trough deeper there. On the distal, if you trough deep, you're going to go through the socket. You'll be into the medullary bone, and you get a lot of bleeding there too. It wouldn't be real harmful, but it's not necessary. It's not going to help you. So it's kind of you're deeper on the mesial, and as you go to the distal, a little bit shallower. On the buccal surface, it's pretty much uniformly deep down to about roughly where the furcation would be. Or on a germectomy, just short of the, where the nerve is, like the cutting surface of the tooth. And if you're not sure, just go shallow and do section multiple times. Section it with the 46, and then come back later. I got it. Thanks. So it's pretty cool. You can see a lot here. You see exactly what's happening. So this tooth is basically out. We're just going to complete this section here, which would be very easy to do. And we're done. So I'm watching the cutting tip of the burr, so I know how deep we are.
Take out the full depth of this part.
So, okay. On this, can you focus on this? If I hold it like this, on the burr. Okay, look at the monitor, guys. You see the burr, and you can see the shank of the burr. So this part at the tip this is what we're looking at, right, to gauge the depth. And one way you know if you're going a little bit too deep too, if you get down to where the shank is, it's going to not feel right too. When you don't, it'll kind of have a burning. You'll feel it vibrate differently. So you don't want to go a lot deeper than this. In most cases, unless you're really sure there's nothing nearby, then you can just go for it. Like one of the slides I showed you on a fully developed tooth, there was no nerve or anything anywhere near, so I would just go all the way through that thing. I've never measured it. What does it look like? 6?
Most of the surgery is still towards the buckle.
Yeah, that's what
It
he
did
was
not
saying.
look like anything underneath. This is yours.
Oh, okay, the wrong one. Okay, so basically that's it. We're going to just use the 46 now. Well, pretty much.
Yep.
I think so. Hear the pop sound? So that's I can even see I didn't go all the way through. See right here? I didn't go through the lingual on that. So this is actually a really good one. I want to pass this guy around once you get it out of there. A little bit more than 2/3, but yeah, roughly. This is pretty cool. So this, we have some dogs here. We'll pass this around, but if you look at this, and go ahead and hang on to it. You can see where the section was, and see this is the lingual, and I didn't go all the way through, right? My section would keep going that way. That's towards the lingual. Okay. The same thing, we're going to go through the follicle here.
I have measured.
Oh, Miju, I forgot about that. Miju, it's really easy. This one was the kind of the classic.
Yeah, that's
doesn't always happen like that, but section it and it comes out in both in 2 halves. Monica, you're awesome. Yeah. Good job. You can get a job in Hollywood after this, right? Yeah. Wayne will be picked up. You're going to leave. Yeah. I do my best to get all this stuff out of here. Okay. That's good. I'm just going to check these edges here, and it looks really good. Nothing rough there. I'm going to get all the loose pieces out of it if you can. Good. Now we're just going to really flush the heck out of this. Like that. And then Jonas is going to switch with you in there. Give you the other tip. Okay. And then there's a little stuff that went up there. It looks really clean. Okay, you want to see what it looks like when everything is clean, ready to close here?
Wow, beautiful.
You can see how it looks. Sorry.
You are not scraping the floor, right?
No, not at all. Just the edges. They're on the side. Same thing on, especially on the uppers. Don't go all the way to the top, right? Just around the edges. If you look at this and you see how clean it looks, and how beautiful it is. I mean, it's easy to see why it actually heals pretty good, right? because it's not. There's nothing happening to the bone. It's not traumatized really. It's just the flap, and that's going to heal great when we close it properly. So, alrighty, so let's see. We're looking for
Sutures?
sutures right here. Okay, good. Okay, so there we go. And then I, want to check, make sure your papilla. See, like how the papilla here is folded under. So I got to make sure that you don't close like that. You got to kind of manipulate the papilla into position. Let me get this thing back. There's one in there. See? I've done that before. It doesn't heal great when you do that. So as close as you can to the second molar. Take a big bite.
Never use the glue stitch for the.
No. Not what is that called?
Yeah.
Periacryl or something. Yeah. I've used that in implants before, but not with
for the tooth area. Kind of to keep the papilla in place. And
all I can tell you is that it's
never
not
had
necessary.
them, right?
You don't need to do that. I mean, I don't think it would be harmful, but you don't need to. Okay, sometimes you need to grab that when it's like this.
Yeah. Right.
So somebody can grab the end of the suture needle, just kind of pull it through when I let go. Okay, good. Okay, beautiful. We're good there. Okay, beautiful. Thank you. So on this one, for years I would just tie it right here, and I realized I wasn't tying a square knot. So now I let go on the right side, and then I grab this end, and now I get you can see how the knot is. It's going to end up being a square knot, or it doesn't slip. Where's the end? Okay, got it. I just try to make sure that this knot is really tight. Oh shoot, something got hung up here. Having problems with this. There's a knot in here that's not supposed to be there. I don't know what happened to that. I have an idea. Let's cut this here. I have an idea. It's kind of odd. Oh, okay. I don't know if I can do that now. I cut the wrong one. I might be able to do this. Oh, it's already, yeah, I can probably get one along there. I don't know. Let's see, it's going to be interesting. Try.
And hold it grab the best one, yeah. The two hemostats.
Yeah, that's going to work. Oh, it came out completely. All right, need another suture. Okay, I'll try with that. Oh, this is plenty. I can deal with this. Okay. So let's see that. Oh, that's yours. I'll use mine here. Okay. That's good right there. I got it this time. Yeah. Sometimes it pulls back. Okay.